Good. Okay. So as Emma said, this is the topic. This is mine, how multi-cancer early detection tests, or I will call them MCEDs for cancer, may contribute to overdiagnosis by consumer testing and screening. Here are potential conflicts. Grail was an early MCED developer. I worked for them for a few days in 2017. Why are you laughing? We can talk about that later. These are current. I don't think that the NCI has a conflict, but it's there anyway. So this is the background. MCEDs in development are being promoted to the public, the profession, and the government, and they may be adopted in the United States without evidence about benefit versus harm, without a clinical trial. And the issues that we're going to discuss today are, do MCEDs work, which means do they discriminate, cancer versus not, and do they lead to improved outcome? That's the goal of all of this kind of activity. How could MCED use lead to overdiagnosis if they become widely used? What are the unintended consequences? Why do we have to anticipate any of this? And then how to manage development, research, and adoption of MCEDs. This is a slide that shows many MCEDs are being developed. It's from a recent presentation from the NCI, the Division of Cancer Prevention, that's organizing a clinical trial about MCEDs, and there's a tidal wave here. Grail is at the front of this tidal wave. There's lots and lots of developers. All right, so here's the MCEDs that are being developed, and these are the topics that we're going to talk about. And the first one is, do MCEDs work? Do they discriminate? So what is an MCED? Well, the definition is it's a blood test to detect multiple cancers early, which means before symptoms. Note here, it does not say early cancer. It says cancers early. This is not a mistake. This is how these things were conceived. If you go back and look at the history, that's going to be important later. And to detect cancers not screened for, this is among the advertisements. And the approach, we're going to use Grail as an example because they've got the most data, and we'll look at their history in a minute. What Grail does is it measures blood DNA, mutations, methylations, and so forth. Grail doesn't measure proteins, but other people do, extracellular vesicles and so forth. And then you analyze what you've measured with math, AI, bootstrapping, and all sorts of things to calculate specificity and sensitivity, discrimination, and tissue of origin. You've got to figure out where's the cancer because you just got a blood test result. And the results lead to imaging to identify the presence, location, and then treatment. The results are limited, meaning for discrimination, the sensitivity results are not high. We're not going to go into that in detail. They're likely overestimated because you don't work up people unless they have a positive test, and you don't know if you're missing people who are negative. The specificity results are high on purpose because that's how people tune their tests. They don't want a lot of false positives. Tell patients you might have something and then we've got to do a big workup, but there's nothing there. About outcome, there's no results at all. The benefit and harm results, they are not existent, but in spite of these limitations, there's enthusiasm, promotion, and some adoption. So let's illustrate these issues and look at Grail. This was an early MCED company. It's been going on for 8 years. They've gotten and invested and spent $10 billion in development. The marketing now of the Gallery test, which is about $900 as an LDT. In the United States, this is a laboratory developed test. The bar for when this gets used is very, very low. You don't have to show efficacy. It's a funny kind of animal. I'm not going to discuss it in detail, but this kind of thing can be marketed. And it may not have FDA approval and so forth, but it can be marketed. And if it's popular and people want to pay for it, or insurance companies, they can do it. The expertise involved with Grail was they measured DNA methylation and other DNA things, and they got together, two great companies. Illumina does great sequencing. It is absolutely top-notch. They have great mathematical analysis. Grail was founded by Jeff Huber from Google, who developed Google Maps or Waze or something like that. He came with $100 million, and his wife had died young of cancer. He wanted to solve problems. But you also need research design and clinical epidemiology, which is one reason I sort of explored them years ago. And the bottom line is that there is not much. This is, in my view, sort of an understatement. And when you think about what you have to do to develop a test, turns out that research design and clinical epi is actually important. This is a whole nother story. The approach is the results express likelihood of cancer and tissue origin, favoring high specificity, limits false positives like we talked about. It also reduces sensitivity. And the status in 2023 is it's in development. It's being marketed as an LDT. Clinical trials are being planned in the UK. It's a little bit further along than the NCI in the US. So here's some information about marketing. This is the Gallery test information for providers. You can see here it is a breakthrough test. It is designed to detect previously undetectable. I don't know if you consider that a big claim or a little claim, but that's what the claim is. And then they say large clinical studies support the Gallery test. Committed to the utmost scientific rigor, the test has been studied in 20,000 patients in 2 clinical trials by leading cancer institutes, including, and they list them. Now, when I think of clinical trials, and I hope when you think of clinical trials, I think of a randomized comparison where you're looking at an intervention and you're looking at outcome. These studies aren't, and we're going to talk about the Pathfinder study, which is the main one. This is information for patients, and what you see here, this is an anecdote. Here's a patient. He's 75 years old. He was an employee, and he had cancer stage 2B, detected resectable pancreatic carcinoma. Now, do you know what resectable means? You know, as an internist, we always tease surgeons. Resectable means you can operate on it. It doesn't mean that there's going to be a better outcome. And of course, you know, you have to operate, and many operations are obviously wonderful, but this is a claim that, if you look at it closely, is really kind of limited. Let's look at the Pathfinder study, which is one of the studies that they point out as being a clinical trial. Its purpose was to identify cancers not screened for in 6,000 people in 7 U.S. healthcare centers, and to learn about their diagnostic odyssey. What gets found? What sort of workup do we have to do? How invasive do we get? Are we hurting people? That sort of thing. A very fair question. It is not, however, a study of either discrimination, sensitivity, or specificity, discrimination, or outcome. Do people benefit? They administered the test, they did the workup, they followed people up for a year. And this is the results: diagnostic resolution in 2 to 5 months, and it involved, among people who were positive, true positives, false positives, a total of 90. Median number of days to diagnostic resolution was 50 to 162. So it takes a while. You have to go in front of a committee of subspecialists and radiologists and so forth to try to figure out, how far do we work this up? How far do we work it up before we say there's nothing there and we stop? It's not a totally straightforward thing, because the differential diagnosis is so wide. They don't know from a blood test exactly what cancer you have. These are the results in terms of the extent of diagnostic evaluation. Imaging, of course, was used in basically everybody who had a positive test. And there were invasive procedures, but most of them were non-surgical invasive procedures, like endoscopy, skin and needle aspirates, core biopsies, and so forth. In the true positives and false positives, surgery just to make a diagnosis. So the invasive procedures weren't that great. This, however, is where their idea of harms stopped. They did not look at things like treatment, and as we get into it, treatment's going to get complicated, and it has potential harms. It wasn't the purpose of this study. The point is, it's just not there. Here's the cancers that they found, and we're going to spend a little time on this slide. Cancers detected after a true positive MSED signal. There were 36 cancers, which, let's see, 26 of those lacked standard screening. That's really their main focus. So let's look what they found in the 19 solid tumors. In orange are breast, lung, colon, and prostate. These are the standard of care cancers that we have. The Preventive Services Task Force and so forth in the United States says, yep, there's evidence you can screen for these. The yellow balls mean stage 3 or 4. Stage 1 is a triangle. So if you look at the orange here, everything that got discovered was late stage of the standard of care things: lung, breast, colon and rectum, prostate. If you look at the non-standard of care things, these are the blue things, we've got really small numbers: pharyngeal, intrahepatic bile duct, pancreatic, small intestine, and so forth. These are very small numbers. Think if you're the NCI and you're trying to figure out how big do I have to make my trial if I'm going to do an intervention trial, and it took 6,000 people to get these small numbers. The point is, it's small numbers scattered. Let's look at the hematologic cancers: plasma cell disorders, lymphoid leukemia. Lymphoma is the main thing they find. 12 of them, presumably lymph nodes on imaging. A lot of these things are pretty advanced, very advanced, the balls, fairly advanced, the squares, small numbers here. This is what the record is of what they find when they look at 6,000 people. Just a rough idea. There's just one data point. So the results are the detection of late-stage cancer early, and we've got to ask, is that a benefit? Because the discovery of late-stage cancer early isn't considered a benefit in clinical trials of screening that we've done on prostate, lung, colon, ovary, and so forth. Because what we do now is we target early stage cancer and surgery to cure. We rely on surgery. And even in clinical trials of looking at surgery and finding early stage cancer, late stage cancers get discovered. So there's some evidence about whether discovering late stage cancer early makes a difference. Clinical trials, they're not designed to do that, to study that, but there's data buried in there somewhere. It's not considered a victory if we discover late-stage cancer, because historically, it's been hard to treat. We want to cure people with surgery for early. Late-stage surgery, in contrast, requires really advanced surgery. It's more complicated, and advanced medical therapy, and especially with modern therapy. So the comment here is that the goal of discovering late-stage cancer early, which is what MSEDs are touting, is a new kind of goal. There could be benefit if cancer's in an earlier part of a late stage. Instead of a 4, it was a 3, or it's an earlier 4 than a late 4. There could be benefit if the patient's healthier, and when you talk to oncologists, they're eager about this. Harm, though, occurs sooner when treatment happens sooner, and it's possible that might be net harm. So does harm occur with early detection of cancer? Here's a clinical trial. And there's not a lot of data on this. So this is a setting of ovarian cancer patients who were in complete remission following platinum-based chemotherapy to CA-125 surveillance, which OBGYNs and oncologists do. Does surveillance with CA-125 improve outcome? The design of the trial was surveillance every 3 months versus just to wait symptoms. And in the surveillance group, the results were recurrence was discovered earlier by 5 months, but there was no improved survival. And the side effects started 3 to 4 months earlier because people got identified and they got treated: fatigue, deterioration of emotional function, social function, and role. This is a neat study by Rustin from Harvard. It was in the Lancet. They don't detail exactly how severe these things were, but those were the side effects they mentioned. And their conclusion was, hey, people, we've now got a clinical trial that says don't do surveillance, so let's pay attention to that. And then a follow-up study was done by somebody else, Esselin, 4 years later, and they found that surveillance behavior hadn't changed. The OBGYN societies didn't endorse it, and everybody seems to be in love with surveillance. And then Goodwin wrote a really neat editorial where he said, let's do a thought experiment. What would behavior have been if a clinical trial had showed a drug to have no survival benefit with side effects 3 months earlier? He didn't answer the question. It's a rhetorical question, but he thought people would sort of glom on to the answer. Not much followed after that, but this is a big deal. And if we look back on this experience and think about MSEDs and what they're likely to be doing a lot of, this is just one example, and it's very old. And there's a lot of really wonderful modern therapy that's very exciting, where we could cure people with middle stage and maybe late stage cancer, like testicular and so forth. But this is one example, but it illustrates that harm occurs immediately after diagnosis, and so it's sooner, and that we think differently about evidence needed for tests versus drugs. So let's talk about overdiagnosis. And we're at the we're at the tail end of the talk here, but we set the stage. What does all this I've been telling you have to do with overdiagnosis? Well, overdiagnosis occurs when diagnosis leads to more harm than benefit. If cancer won't harm, is slow growing, and treatment harms, like many prostate cancers, MSEDs don't discover many of these cancers. They're going to discover later things. This is not going to be a problem with MSEDs. If cancer could harm, but the patient is older and may die of another cause, like colon cancer over 75, don't screen. MSEDs may discover some of these, but MSEDs are discovering a new kind of animal. But I'm going to make the case that your group ought to be interested in this. MSEDs generally discover late-stage cancers that will harm you, and everybody's going to want to treat cancer. But if treatment is ineffective, thank you, Barry, for this idea. If treatment is ineffective, because I thought this is overdiagnosis, it's not. This is ineffective diagnosis. Net harm will occur from earlier detection, and do we, the profession and the public, want this as policy without evidence? Do we want to use a drug that hasn't been shown to have a benefit and causes side effects earlier? That's sort of where we are, but it's not a drug, it's a test. Ineffective treatment is not exactly overdiagnosis. It may be overtreatment. It's going to get you into that sort of swamp about overtreatment or overdiagnosis. But the issues are very similar about benefit, harm, consumer perception, marketing, and actions, which is what we have been talking about all day at this meeting. So let's look at marketing and what's going on there. Marketing MSEDs to consumers in the profession, the longer 5-year survival means benefit is promoted as showing benefit. Grail in the Quest for Cancer Detection says here in the caption, individuals diagnosed with localized cancer, these are the green bars, survival rate, here's a bunch of different cancers, are more likely to be alive 5 years after diagnosis. So let's look at this. We've got ovarian cancer, 5-year survival. If you discover it localized, it's real good. Discover it later, it's real bad. This didn't come from a clinical trial. We've had 2 gigantically frustrating, disappointing PLCO and UKC tox clinical trials. This is observational data about where, because of lead time bias, we're just sticking the label on somebody earlier and they live with the diagnosis longer. It's lead time bias. The first author of this paper, who's now the president of Grail, he's got a master's in public policy from UCLA. I couldn't find out if epidemiology is taught as part of that degree, but lead time bias, this is a capital crime in the United States in epidemiology. You don't rely on lead time bias. Even, Barry, if you're the director of the National Cancer Institute testifying in front of Congress. The U.S. Congress also thinks that longer 5-year survival equals benefit. Here's a bill to amend the Social Security Act, blah, blah, blah. Here's the title. Findings and purpose. They start off with a background. It's like you're writing a grant. It's the preamble. By the way, if you guys have never read the preamble to the Declaration of Independence, you ought to read it sometime. It's absolutely fabulous. It makes such a great case for why the United States had to break up with England. It is absolutely beautifully written. This isn't. Detecting Thomas Jefferson had nothing to do with this. We need smart people in Congress. That's another problem. Detecting early cancer before it is spread through the body saves lives. Cancer detected when still localized can be treated more effectively and have a 5-year cancer-specific survival of 90% compared with blah, blah, blah. Now, they don't say that early detection causes, but they're pretty close. Can be treated more effectively and have these people are not thinking. If a second-year medical student did this in your clinical epi class, you would flunk them. And this is the United States Congress, can you imagine? Other MSEDS claims are appealing, misleading, and incomplete. 5-year survival, cancer detects cancers not screened for. So what? That's not the problem. I'm going to finish in 3 slides. The cancer is not screened for. Low false positive rate is a prime measure of harm. No, we have treatment. Advances equity? Nope, don't buy that. In the test, yes. What about treatment? High quality surgery, high quality medical therapy. So how do we address these issues above? Can this group's expertise in overdiagnosis help manage ineffective diagnosis? Can consumers be educated? Consumers demand and MDs prescribe. Can physicians be educated, or is this a problem for the FDA? The environment of MCED adoption is like for PSA for prostate cancer. I'm going to leave this slide, which is one of my favorites, but I'll send the slides to anybody who wishes. If they become widely used, there's unintended consequences. Contamination of clinical trials can make acquiring clinical trial evidence difficult because of contamination. When you're doing the trial, here's some examples. There's harms to people, like for PSA. And I'm worried that the whole idea of evidence-based medicine is going to get corroded if we can bypass the requirement for evidence of benefit here, then why not elsewhere? I don't think regulatory mechanisms in the United States may help. These companies may get around regulators by using lab-developed tests. Guidelines makers, the task force is going to resist, but there's other guidelines makers that have less trustworthy processes. And the conclusion is that they may become used without evidence of efficacy. It's not overdiagnosis, but ineffective diagnosis is a close cousin with a similar culture, environment, and consequences. Expertise from your field may help understand and manage this cousin, but can education of consumers or even physicians manage this, or is regulation needed? I will be very interested to hear your field's advice about how to proceed with this very parallel kind of problem. Thank you very much.